Welcome to the Cyber Health Podcast, where we share science-backed tools and expert insights to empower women's health and elevate their lives.
Welcome, everyone, to today's special Cyber Health Podcast, brought to you in partnership with the Evolution of Psychotherapy Conference. I'm Dr. Dustin Weissman, and I'm honored to be joined by someone whose work has profoundly influenced our field. Dr. Anné Zeig is a nationally recognized expert in eating disorders, complex trauma, and attachment repair. For more than 3 decades, she has been pioneering a powerful framework that bridges the gap between unresolved trauma and chronic struggles with food, weight, and body. She is also a Mayo Clinic faculty member, an on-air psychologist, and the author of the acclaimed newsletter, The Second Time Around, What Curing Eating Disorders Taught Me About Healing Complex Trauma, The Power of Healing Attachments. She will also be releasing quite a few new trainings in 2026, so make sure that you check out her website, drjuliannezeig.com, for more updates. Her message is one of hope, healing, and full recovery, and we are thrilled to have her with us today. Dr. Zeig, thank you so much for being here and welcome.
Thank you so much, Dr. Weissman. It is both an honor and a pleasure to be here with you today. I'm really looking forward to this conversation.
Great, thank you, and I am too. So let's jump into it. You often talk about the importance of healing complex trauma for treatment of eating disorders. Can you know what that means for clinicians who still treat these as separate issues?
I actually think that it's really hopeful. I think that trying to treat these two oftentimes interwoven disorders really is a way that obstructs the efficacy of really traditional eating disorder treatments. I truly believe that when we widen our conceptual lens, when we widen our assessment process, and we step in and we heal underlying processes, the cognitive behavioral aspect of our treatment is enhanced. So I think it's a positive thing. And we do need more efficacious treatment for full recovery.
And do you feel that the field of psychology has been slow to integrate trauma with mainstream eating disorder treatment models? And if so, what do you think has contributed to that?
We absolutely have been slow to integrate trauma into our treatment models, and I am not sure why. My hypothesis is that because eating disorders present really with a dual psychological presentation, but also a physical presentation, and oftentimes it is very, very frail. So we are talking about working with underlying trauma, and I think that historically, the fear has been if we address the underlying trauma and we shake things up, we are going to activate more disordered eating. And that's super scary when we're working with someone that's 86 pounds. But what we don't recognize is that if unresolved complex trauma is part of the eating disorder equation, the only way that we are going to truly stop the revolving door of the back and forth, right, is to be able to treat the underlying trauma. And let me explain that. Let's look at somebody that is grossly underweight, let's say 86 pounds, 5'7", and obviously they need to restore their weight. That's imperative. But when they restore their weight, they start feeling their body self. And if that body contains memories or feelings that have been contained, have been disconnected through the self-starvation and through the weight restoration, we reconnect and we don't address and help to work through the trauma, then what ends up happening is people regress. They go back into the restrictive eating, they lose the weight, and they disconnect from their experience of their body and of their emotions. So we need to look at treating this cautiously, but concurrently. That's been my experience.
Fantastic. And you speak candidly about the limitations of cognitive behavioral therapy and other surface level behavioral models. I'm wondering what's missing in these approaches and what happens clinically when trauma is ignored.
Well, I think it's really important to state, and I always do when I present, that I actually have a lot of respect for cognitive behavioral therapy for eating disorders. I think it is a sound, evidence-based form of treatment that I use with my clients every single day. So there is nothing wrong with the tenets of cognitive behavioral therapy. But what I have found is that in the presence of unresolved complex trauma, it actually works to obstruct our client's ability to work with and achieve the tenets of cognitive behavioral therapy. And I can go into explaining that. It's imperative that we understand this because for cognitive behavioral therapy to work, and this is the goal, we want to be able to utilize this, we have to realize how unresolved complex trauma is deeming that really not possible.
Yeah. So I'm wondering also what other maybe early life relational wounds again and again in your work with eating disorders.
So if I can, I'd like to share a little bit of a conceptualization that I think really illustrates these points that I'd like to emphasize. And for all of my clients, but especially my eating disorder clients, I want them to be able to connect up with their body. I want them to connect up with their physiological cues of hunger and fullness. I want them to be able to connect to their physiological cues of emotion, right? We are first and foremost that arousal, the physiology shows up, and those are our emotions. We want to be able to connect with them. We want to identify them. And then we want to be able to respond to them in a loving, consistent, need-fulfilling, and supportive manner. Similarly, we want to have a healthy relationship with ourselves, and we want to tolerate emotional intimacy, physical intimacy, and sexual intimacy with others. Okay. When we look at complex trauma, and I really like to call it developmental trauma because it still is very misunderstood in our field. All right. Let's think about somebody that is 3 years old the first time they're starting to be fondled by their grandfather. Okay. And they're 5 years old the first time they're penetrated. They're 8 years old the first time that they are raped. And this is happening in their home with their parents present. That child goes to their mother, who, by the way, was also sexually abused by that grandfather. And the mother slaps the child and says, "Don't say that. How dare you? Okay, you're crazy. Nothing happened. Right? Don't tell me about that." And so the child goes to school, tells the nurse, okay, an agency comes out, the family gets in trouble, and the child is emotionally alienated from the family. Okay.
Yeah.
So then let's look at eating disorder treatment. Okay. And let's say, how do you feel? Right? When you get triggered, let's connect up to your body. Let's connect up to your emotions. And how do you feel? Right? Well, that child at age 3 and age 5 has disconnected from their body and disconnected from their emotions. Right? And because they were told that they were crazy, they were gaslit, they start to gaslight themselves. I don't know how I feel. What if my feelings are wrong? what if I'm just bad? Right? And then they don't respond to themselves. They don't respond to their emotions. And instead, they get activated, they get aroused, and then they find themselves unconsciously reaching for food because that is our first unconscious default self-soother. Okay? So if we look at the very sound tenets of cognitive behavioral therapy, first of all, we want to value ourselves, not based on our body weight, shape, or size, but value ourselves for multi different aspects of our identity. But if we hate ourselves, right, because we were treated neglectfully or emotionally abused, right, we don't devalue ourselves because of our weight so much as just ourself. When we talk about identifying our feelings, we're not able to do that. Okay. So this is how we need to treat these processes first so that it becomes safe to connect up to your body, safe to connect up to your emotions. You become caring enough about yourself to respond to your emotions readily so that there isn't the misuse of food, right? So this is how, in the presence of unresolved complex trauma, it makes the sound tenets of cognitive behavioral therapy really great in theory. But for a large part of the population, in practice, it's not possible. Okay?
Yeah.
So our clients don't know why they can't do that. They don't know why they become overwhelmed. They don't know why they dissociate. They don't know why they go into binging with food. As clinicians, we need to be able to thoroughly assess, have a developmental trauma assessment, understand, put this 2,000 piece puzzle together, and then help them eventually be able to connect in a healthy way where they have a positive relationship with body, emotion, self, and others. That is complex trauma work. And what I have found is when we do that, then CBT becomes more effective. And isn't that wonderful? Then it makes more sense and our treatment efficacy goes up and we can reach full and lasting recovery. So I believe that this is imperative that we start recognizing complex trauma and be able to treat it and understand how it gets woven into the attainment of a maladaptive relationship with food and body and how we can shift that.
Yeah, I think I was just kind of envisioning if I was your patient for a moment, as you're talking about the upbringing and you really breaking it down, the framework, and looking at some of the depth that's involved that maybe CBT doesn't typically address, and how that evolves to be something that we later cope with, which CBT does a fantastic job at addressing, as you're saying. So yeah, I'm just like, yeah, I love that approach. Give you some education. I love doing that with my patients, and I think it's super important to let them know where they're coming from.
And Dustin, I get this response as I travel throughout the world. It's like everyone's like, yes, this makes sense. When we break it down this way, it makes a lot of sense. We need to do a lot more education regarding complex trauma because so many times people think of trauma. And there certainly is overlap between trauma and complex trauma, but there are also profound differences. I like to say that big T trauma, let's say that occurs in an adult, is trauma that imposes itself on an intact psyche, whereas complex trauma impacts an unfolding psyche, right? It becomes part of the unfolding development of self and of body and emotions. And so we have to recognize that and we have to treat that so that eventually our clients can have a healthy relationship with themselves, what I call a healthy attachment relationship with themselves. And that's always my goal of my work. is for them to internalize the attachment repair that happens therapeutically and internalizes that so they can ultimately create that healthy attachment vis-a-vis their relationship with themselves. That's why I call my newsletter the second time around. If we don't get a healthy attachment relationship the first time around, we can cultivate that even in adulthood. And isn't that hopeful? Isn't that beautiful? And isn't that true? It is.
Yeah, I love you're dancing around my next question, so I'm just going to ask you before you completely answer it. So your strategic attachment repair approach is powerful. Can you walk us through how the therapeutic relationship becomes the central tool for healing?
So again, we have to understand complex trauma as different than big T trauma. And complex trauma at the core is interpersonal trauma. Okay. It is interpersonal trauma at the hands of our primary caregivers, which are typically our primary attachment figures. And this happens very early in life during our formative years. Okay. So the psyche does all sorts of things to survive chronic, multiple incidents of ongoing trauma. And it impacts your ability really to have intimacy with others and, self and body. So in the therapeutic room, in the therapeutic relationship, how can we not recognize that there is a piece? We are in the room. We are in the room with the client, with ourselves, and the interpersonal trauma that is impacting the present work. Okay. So it is impacting their sense of safety, right? How they open up to us or not. And it is really, so we have to recognize that, but we can also utilize it, right? So we can utilize it so that if we are strategic and intentional, this goes beyond rapport, it goes beyond attunement. It is a result of very thorough assessment of developmental history, including our attachment history, right? And then utilizing those subtle details to then weave that into the here and now as it either shows up in the therapeutic relationship or as we can creatively craft it so that we can do intentional and strategic repair. Okay. It doesn't matter if we have a healthy attachment early on. That's a beautiful gift if we get that. Okay. But we can repair it in adult relationships. And the goal is once you have an attachment relationship that is healthy, we want to help our clients internalize that so that then they know how to have a healthy relationship with self. Because we repeat the early maladaptive attachment, and we can also create the healthy, loving, and supportive attachment. And that's the end goal of the work.
Oh, good. Let's talk about end goal because I where we're going. I love goals.
Okay. I need to plug in my computer. So hold on one
Plug in your computer.
Okay. Let's see. Hold on. Okay, there it is. Okay, got it.
All right. So what does a fully recovered client look like through your lens? Not just symptom free, but psychologically and relationally transformed. You're muted.
So they have interoceptive awareness. Okay. That is the ability to consistently connect up with your body, right? Discern those emotions and respond in a need fulfilling and self regulating manner. Isn't that wonderful? Okay. They are able to use their voice, right? They are able to talk about what they are feeling and what they are needing to others. They are able to live from their real self, who they really, truly are. They have the strength, they have the confidence, they have the self-worth and self-esteem to live from that place. They use food for what food's supposed to do. It's supposed to physically nourish our body, and it's supposed to give us pleasure experiences as well, but not be the only way that we get pleasure. So therefore, we give ourselves pleasure many other ways. We support ourselves in soul-fulfilling activities and interests, and we are able to connect with others and be vulnerable and intimate on all levels. Okay? This is full recovery. You are able to walk around in your body, not hating your body every moment of every day. You can walk around and not even notice your body. Now, if you have never experienced an eating disorder, you probably don't know what I'm talking about. If you have experienced an eating disorder, you probably know exactly what I'm talking about. Okay.
Yeah.
It is the ability to move about in your own skin, your own space without apology, and to have all of this extra energy be spent loving others, being creative, fulfilling. That's full recovery.
Beautiful. So you mentioned that clients often don't even know what they're feeling when they turn to food. How do clinicians help the patient with their emotions without overwhelming them, especially when that trauma is present?
Yeah. They are going to get overwhelmed. Okay. So we have to have that detailed developmental history. We have to continuously be attuned and track and adapt. We have to tailor ourself and our work to every patient. We need to do that anyways, but especially with complex trauma survivors. So ultimately, gently and consistently, cumulatively, eventually they can get comfortable. But there's going to be potential dissociation, there's going to be shutdown, there's going to be agitation, right? So there's going to be lots of pieces, and we have to understand them as they speak specifically to that client. And we need to address them without judgment and ultimately in a safe space help them to connect up with those emotions. That's the art. And that's the necessity. Because again, how can they utilize CBT without then being able to tolerate connection to their emotions? They can't. So that is the task. So deliberately, gently, with compassion, uh, conceptualizing with patience, and really being informed. Okay, we need to be more informed. We're going to be so much more effective with all of our clients, and especially with eating disorder clients. This is my hope for the future of our field.
Yeah. I think a lot of clinicians, they oftentimes get stuck when they're trying to treat trauma-driven eating disorders. I'm wondering what advice you might have for them and how they can pivot towards more effective repair.
I'm so sorry. I got distracted because I saw that I was muted. So I'm so sorry. Could you
I
read
think
that?
I'll read it again. I'll go through it again.
Okay.
Uh, okay. So, where do clinicians most commonly get stuck when treating trauma-driven eating disorders, and how can they pivot towards more effective repair?
I think the biggest thing is that clinicians might have a blind spot. So as I discussed earlier, if somebody is going through weight restoration, which is horrifically hard for somebody with anorexia, and they are restoring their weight, but then they hit a roadblock and then they regress. It is so easy just to say, okay, it is because they're uncomfortable with their weight, they feel fat. We can look at it from the eating disorder perspective only, and parts of that are certainly going to be true and present. but maybe it's something else. Again, maybe they're feeling their body. Maybe their body is changing. Maybe they're starting to menstruate again. And that for them is connected to abuse or being a woman. Okay. So we have to be sensitive to that. And, as I just mentioned, menstruation in women, I want to acknowledge this is true of men as well. We know that unfortunately, men go through trauma as well. Men definitely struggle with eating disorders. It's now 25% of those with anorexia and bulimia are
Wow.
boys and men. 25%. It used to be 10%, and that statistic has jumped up.
Mm.
So when we are assessing a patient, we need to recognize it's not just teenage girls or young women. It can be men, it can be middle-aged women, right? Unfortunately, the landscape of eating disorders is really expanding, and we have to be aware of that as clinicians when we are trying to differentiate between diagnoses.
Yeah, imagine that social media might have an impact. I know because I know, but we won't delve into that too far.
Yeah.
I'd actually like to pivot a little bit back to what you're working on.
Uh,
So you've launched your new educational newsletter the
yeah.
second time around, and I'm wondering what inspired it and what hope do you have for professionals and the public to gain from following your work?
So, what inspired it is that I have about 7 books that are in my heart. Some have been started, and unfortunately, my life is so busy that I have not been able yet to publish those books. And so, whenever I do a training, people are always saying, "Oh my gosh, like, how can we learn more?" And I love to write. I love to teach. I love to give people hope and tools. So I thought, let me do a newsletter and let me put components in there. I have the soul of psychotherapy. I have attached to food no more with KNOW no more.
Okay.
So I really want to continue the education that people are asking for. That's why I'm doing a lot of trainings in 2026. And I love writing. I have also been told, and I say this like, I don't know, it's a little strange to say this, but people become inspired, kind of by some of the things that I'm doing and such, and so they enjoy that. And Instagram is not something that feels super comfortable for me. The work feels so deep that it just doesn't feel like a platform so much for me. But I want to really um, help people and lift people up and give them tools and skills for them to continue their journey of healing. So that's what my newsletter is all about. And I really enjoy it.
That's wonderful. Wonderful message, wonderful motivation behind it. I love that your goal is just, inspire and help and educate and train. Yeah, as social media should be. I like we need more of that on social media.
It's difficult, so we find what's comfortable for us. And, and touching lives and helping others is what it's all about.
Hmm.
So,
Yeah. So let's talk about others and family and
yeah.
holiday season. When we filmed this, it was just before Thanksgiving. By the time people are seeing it, it's probably after, but still the holiday season, which are supposed to be joyful, but they often activate old emotional wounds, especially for individuals with trauma histories and eating disorders. Why do you think this is that when people gather for these holidays, they're experiencing this?
So the most obvious that people think is, well, you're around family, right? And family triggers, and if it's dysfunctional, that's going to trigger you. So that's one of the most obvious. And I think that that's really true. But I don't think that people recognize that um, if you're a complex trauma survivor, your holidays might not have been good, right? So even if you now are in a situation where there is joy and you're seeing kind of gathering of other people's families, there are going to be those memories, right? If it's unresolved, there are going to be those memories. And too often, people are not so completely connected with why they are feeling a certain way, right? And everyone focuses on, so much the here and now, and we don't really, kind of stop and have deeper conversations about how this might bring up different things for different people. So I think sometimes there's grief and loss. Sometimes there are intrusive memories of, holidays of the past, and it can be bittersweet. So I always try to be sensitive to that with people around the holidays. And I think that that's something that we should just be conscious of.
And then we get into the post holidays, right? New Year's, and then January, the gym memberships go up. I'm wondering, what are reminders that someone can tell themselves after the holidays instead of the typical, oh, I shouldn't have eaten that, or oh, I need a diet now.
Yeah. Well, I think the very first thing is that everyone deserves to have joy and pleasure. And we all do get pleasure, right? From our culture and our rituals around food. That shouldn't be shamed. We shouldn't shame ourselves for that. Our relationship with food should not be equated to our moral compass, right? It doesn't tell us is our character good or not with how much we ate, how many pieces of pie or not. Okay. So we really need to separate that out. And I always remind people that dieting, okay, is usually one of the things that creates this disordered journey with food. We know that. It is consistently researched that dieting predates binge eating behavior. And binge eating behavior creates eating disordered behavior and also issues of obesity. And I say that without judgment. I have no judgment over someone's body self, but that is well researched.
Mm-hmm.
So it's never the goal to go on a diet. All right.
What is the goal?
The goal is to have a healthy relationship with food. Okay. Ultimately, to be able to eat intuitively, right? Based on our physiological cues of hunger and fullness, and to respond to our emotional cues in direct and loving and need fulfilling ways. Okay. We also want to have a healthy relationship with movement, not to burn calories, but to support our well being, to care for ourselves. So we want to be able to move regularly in ways that feel good. And we never want to diet. Okay. We want to eat all foods in moderation for the right reasons. We have a lot of undoing of dieting mentality. And so this is of course part of cognitive behavioral therapy. This is part of any sound eating disorder treatment. We want people to be able to stop dieting, start eating normally. Most of the time that is with intuitive eating because it's based on internal and not external. And, to take care of their emotional needs in a healthy and direct way. We can do that when we've worked out our underlying complex trauma. These pieces go together. They are and, not or. It's not either or complex trauma. It's what can we do additionally to enhance the efficacy of cognitive behavioral therapy. That's my message.
It's beautiful. I want to thank you so much for being with us today. And I just look forward to your newsletter and seeing all about what you're putting out there and how, all of us clinicians can help our patients, just live healthier, better lives. And thank you.
It's been a pleasure. Thank you so much.